morning, everyone. I am Dr. Prince from UCMS Delhi, and I am here to present a very interesting case studying the effect of topical insulin on a non-healing corneal ulcer. So what happened was a 51-year-old South Asian farmer presented to the OPD with the chief complaint of redness and mild pain in the left eye since 1 month. There is history of exposure of left eye to the farming urea one day before the symptoms started. So the patient did not have much symptoms. That's why he was very much comfortable for the past 1 month, and he was putting eye drop moxifloxacin 2 hourly, which he took from local medical store. There is history of similar symptoms in the left eye 5 years ago following trauma by rice bran, which rendered residual diminution of vision. There is history of left facial palsy since childhood after an ear infection, and there is no history of systemic illness. Right eye ocular examination was within normal limits. Left eye ocular examination, the vision was finger countings at 3 meters and no improvement on pinhole was seen. Facial asymmetry was asymmetrical because of facial palsy. Extraocular movements were foreign free. There was mebomitis, there was lag of thalamus, but the Bell's phenomenon was good. This is the corneal examination. We can see diffuse and circumciliary congestion. We can see 5 into 4 mm epithelial defect, fluorescein stain positive, and we can see the punctate epithelial erosions. We can see infiltration. We can see feathery margins, satellite lesions can be seen. We can see hypopyon, that is 1 mm hypopyon, that it was immobile. And we can see a corneal facet, which was probably due to the previous illness. There is congestion, and in anterior chamber, 4+ cells were present. Pupillary reaction was sluggish but normal, and lens, vitreous, and fundus, because of the hazy media, they were grossly reported to be normal. IOP was within normal limits. So what we did was investigations. Routine general investigations were all within normal limits, such as hemogram, LFT, KFT, blood sugar, viral markers, syphilis, chest X-ray, ultrasound, whole abdomen. They were all within normal limits. What is important was that the posterior segment was not involved despite having 4+ cells in the AC. That is, ultrasound B scan showed only vitreous degeneration with posterior vitreous detachment. On microscopy, gram stain was negative, but the KOH stain was, fungal hyphae was seen on KOH stain. Despite of that, bacterial and fungal culture showed no growth. That was probably because due to lab error or clinical error. We started the patient on broad spectrum antifungal and antibiotic topicals, cycloplegics along with lubricants. We started oral doxycycline for blepharitis, but despite this treatment, for 1 month, there was no decrease in the size of the epithelial defect, although there was significant improvement in the infiltration and hypopyon. For the epithelial defect, we did temporary lateral tarsorrhaphy, but the patient was very much uncomfortable and it was non-compliant, so we released it after 5 days. Then we started topical insulin, 25 international units per ml, 6 times per day, along with tapered previous medications. 40 international units per ml, this concentration is available in our setup. So how did we make 25 international units per ml? We took 6.25 ml of this insulin and diluted it with 3.75 ml of distilled water to get 10 ml of 25 international units per ml. Now we can see the progress. Within 3 days, there was significant reduction in the infiltration and significant reduction in the epithelial defect, which moved to reduce more after 1 week of the starting insulin. As you can see in this image, there is a significant improvement. It was given for 2 weeks, and within 2 weeks, the epithelial defect was completely healed, although the punctate epithelial erosions were still present. You can see the healing of the corneal ulcer. The anterior chamber reaction is cleared. There's superficial and deep vascularization. Surrounding corneal haze is reduced, and the ulcer has moved on to become nebulomacular corneal opacity. Insulin was stopped after 1 week of this. So in total, 3 weeks of topical insulin was given. For 2 weeks, we gave it for 6 times per day, and then it was tapered for 1 week. This is the clinical picture after 2 weeks of stopping insulin. On follow-up, the vision was 6/60. Lag of thalamus is still present with good Bell's phenomenon. So we gave the patient topical lubricants, and all the examination like lens, vitreous, and fundus were within normal limits. So now the patient is planned for optical penetrating keratoplasty. In literature review, most of the studies done using insulin and corneal ulcer were done for neurotrophic ulcers only. In Tong C. Maya et al. In 2020 Canada used 25 international units of this for neurotrophic ulcer, and they noticed re-epithelialization of the cornea within 1 week. Similar results were given by Wong et al., Yavis et al., and other studies, but their concentration varied. They used 1 ml, 1 ml, and 50 international units per ml. There is one thing that in diabetic corneal ulcers, diabetic neurotrophic corneal ulcers, the higher insulin dose should be used as stated by Mr. Bession and Ling in 2013. Now, what is the mechanism behind this? We don't know for sure, but the presence of insulin receptors on the cornea and the lacrimal gland and increased prevalence of keratopathy in diabetic patients suggested that insulin may contribute to corneal wound healing. A rabbit model showed that topical insulin might alter the ocular surface response by increasing tensile strength in corneal wounds, and an in vitro model of immortalized corneal epithelial cells showed increased cell migration and better adhesion of epithelial cells to extracellular matrix. And no adverse effects were noted, no systemic adverse effects were noted with the use of topical insulin at concentrations up to 100 international units per ml in any of the published cases. You can see all these references as I have given here. So in conclusion, topical insulin may be a simple and effective treatment for non-healing corneal ulcer. Insulin-like growth factor along with substance P has been shown to be an important modulator of corneal wound healing. Treating predisposing infections like blepharitis is very important, and exposure of the cornea should be managed properly, because as long as the cornea is exposed, we won't be able to heal the epithelial defect. Thank you so much.
I think that was a very interesting case. We usually first use things like autologous serum, amniotic membrane, but sometimes the penetration of the drug through the amniotic membrane goes down. So using a topical therapy like insulin, I don't think many of us have tried that. But what was the reason that you chose to taper insulin? Is insulin to be tapered? You said you tapered the therapy.
Yes, ma'am. In the study done in 2020 Canada, we took it as the primary study, and they gave it for 3 weeks, and then they tapered it for 1 to 2 weeks, depending on the response. So our epithelial defect healed within 2 weeks, and then we tapered it.
Okay, so as per the literature that you studied,
yes,
the optimum duration is about 2 to 3 weeks to give insulin?
Yes, ma'am, 2 to 3 weeks. But there are no specific systemic side effects, so it was not actually mentioned the maximum duration of insulin that can be given. So in 2 weeks, our epithelial defect healed, so then that's why we tapered after that.
Right, so insulin anyway has a anti-inflammatory as well as an epithelial regeneration role, so yes, it is an interesting use of insulin.
Yes.
So congratulations on your work.
Thank you.
Any comments from the panelists?
AV team?
Do you routinely give, or is it the first case?
No, ma'am. This was the first case, but after seeing this result, we have done this in 3 or 4 more patients, and we are starting to make a case series about that also. We have 5 patients who have been improved by topical insulin, so we'll be publishing that, I think.
So the 5 cases, the 5 cases, they were all infective keratitis, or have you tried in other indications like neurotrophic ulcers or post-graft?
Ma'am, there was this viral keratitis also, that also healed, but 2 of them were fungal, and 1 patient also had systemic diabetes, and 1 was purely viral, so it has shown promising results.
When you prepare the insulin, how long can you use the prepared insulin?
Ma'am, there is no literature that I found but we personally...
I think a lot of the people will be encouraged to use insulin.
Yes,
so
but we refrigerate it. First of all, we make it under very aseptic conditions, then we refrigerate it, and maximum we use 1 vial for 3 to 4 days.
Okay.
Yes,
Nice presentation, Prince.
Thank you, sir.
But for since most of us are resident here, could you just tell us how to manage such cases? Post-infectious keratitis, infection part is almost healed, but epithelial defect is not healing. Okay, so what are the other approaches that somebody can do? Because for preparing insulin drop, you need aseptic setup,
yes, sir.
which is there like centers like UCMS, maybe RP center. But for a practitioner, what are the approaches they have?
Sir, if there is no infective component and if there is only persistent epithelial defect, then we can use, first of all, we have to give a vigorous amount of lubrication for the patient, and we can put BCL, we can put amniotic membrane graft, we can use tarsorrhaphy also. But BCL is, the easiest and most promising in that case. But when we gave insulin to our patient, there was still a bit of infective component present, so we gave insulin along with broad-spectrum antifungals and antivirals.
Yes, because one of the limitation of autologous serum insulin eye drops, since these are growth factors,
yes,
there is a fear that it may incite more infection.
Yes.
Okay, that's the concern that we have. Anyone from the house want to add any question to Prince or the first presenter? Okay, what is the experience of AMG? To the panelist, there are several articles which say that AMG can be done in such cases. So I would like to ask Dr. Astha, Dr. Hemlata, and Dr. Ritika, have they tried AMG in post-infectious non-healing epithelial defect, and what's their experience on this?
I usually do tarsorrhaphy. So most of my patients heal with tarsorrhaphy. So very few cases I have done amniotic membrane graft, and both of them work well. Both the tarsorrhaphy and the amniotic membrane graft. So I mostly prefer tarsorrhaphy for my patients.
I think AMG is also a great tool in neurotrophic ulcers. The infective element having gone, AMG is actually a barrier to the penetration of certain drugs. So AMG is a great tool. We've tried using, in deeper ulcers, even multi-layered. But we normally stitch in the AMG with sutures. You can try glue also, but you need the normal AMG. The ones that they are recommending as the pre-prepared frozen, they hardly have any utilization in our experience. So we are doing the traditional AMG, not the ones that are, pre-prepared frozen. I forgot the name of the commercial. What is the name?
Yes, so in infective keratitis, the AMG is, it is a matter of debate and controversy because there's a lot of inflammation. So the AMG tends to break down and disintegrate because of the inflammation in these conditions, and there's also a chance of it being a biological membrane getting infected. So however, but we saw that it can be useful. It is not absolutely contraindicated in infective keratitis, and in very difficult and recalcitrant cases, it can be tried as a temporary
Thank
bandage.
you. So the basic.
I think for the benefit of the PGs, another newer modality that is still not fully proven, experimental like insulin, is collagen cross-linking. So you should know about that also in the treatment of refractory corneal ulcers.
So basically, tarsorrhaphy, that is available to all of you. You can try that, or BCL, right? If that doesn't work, then you can go for all this innovative therapies like autologous serum, insulin, eye drop, you know. But surprisingly, this drops works well. Whatever the experience that we have with autologous serum or cord blood serum, they usually works well because they contain a lot of growth factor. So thank you, Prince. Now coming back to the first